to everyone for being here. We'll start by going around and telling folks who from the committee is here. Start with the folks around the table, and then go to the telephone. I know we have a couple of folks on the phone this morning, so thanks, Dr. Half.
Good morning, Howard Half from Shaw Associates.
Dr. Vinu Ganti, internist.
Rich Zummel, Union Hospital, Elkton, Maryland.
Dr. Ram Paravemba, First Colony Anesthesia.
Dan Wynn, Care First.
Dana Kaufman, Schwartz, Medicine Wise.
Todd Ittner, Calvin Memorial Hospital.
Cindy Kelleher, University of Maryland, sitting in for Marlene Riley.
Barry Rosen, Gordon Feinblatt.
Steve Force, HSCRC.
Donna Kenzer, HSCRC.
And Rob Cohen, HSCRC. And now we'll go to who's on the telephone.
Betsy Carrier, Maryland Women's Coalition for Healthcare Reform.
Good morning, Betsy.
Hi, it's Stacy Sherdell from United Healthcare.
Hi, Stacy. Thank you. Good morning.
We also have
Okay. Laura, we know you're out there. Thanks for being on the phone this morning. Well, I hope people weren't too upset by coming in at 8:30 rather than 8 this morning, so thank you. So I just thought I'd quickly go over the purpose for the meeting today, the things we'll cover on the agenda. The first thing is Steve is going to talk about the report to the commissioners that happened at this month's commission meeting, so thank you all again for working on the report. And Steve will talk about that and the feedback. Then we will talk about the general sort of work plan for our work group in the context of the overall plan for implementation of policy around the new waiver. So not just the recommendations related to our report, but really all of our future work and how that fits in the context of all the work from all the work groups and how policy development will get done going forward for the new model. And then we'll come back and talk specifically about the implementation work plan for the report that we just did. So that's what's on the agenda today, and we'll start with Steve going through the report to the commission on our work group report.
Great, thank you, Rob. So I guess you all saw Rob had distributed the report on alignment the other day. We reflected many of the comments that were made here at the last meeting, comments that we received via email, and I just want to personally thank you for all of you. This is a long report, and if you look at some of the activities of the other work groups, this is different. I mean, we're looking at the world, whereas a lot of the work groups, at least the healthcare world in Maryland, a lot of the work groups were looking at define things like an update factor. What's the UCC methodology? What are we going to do with data and infrastructure, which is somewhat larger. But the purview, what you guys are looking at is much larger. And for us, there's a lot of education going on both ways here, because there's a lot of education for us, not so much for Donna because she's lived in the world, but at least, and Rob too. But some of us staff have lived in this bubble for a while called the rate setting system, and looking primarily at hospitals. So I think this has been a real help for us to understand what it is we're embarking on, what we're looking at going out into the world. So your input is invaluable, and it's been really helpful. I think it's resulted in some very good recommendations. It's resulted in some defined things that not only we can do, but also that we can do from a policy standpoint, but also things that we can work with stakeholders on going forward, and that's what we're going to talk about a little bit today. But there are also some things here, I think this gathering helps out too. There are some things that we may be ancillary, when I say we, the commission may be ancillary on, where it's really the industry, the providers and payers and other stakeholder groups coming together and coordinating and making things happen in the delivery system. So as we say in the report, I kind of see things as in three ways. One is, what are those things that the Commission can do directly? And you have some recommendations in here that directs the Commission to start down the road on some of these things. There's some things in here that says, well, this is not really a direct Commission policy, but the Commission will really be changing things by incentives in the system, and we need to we need to be part of the stakeholder group that's helping to move things forward. And the third category to me is really, there's some things that's really that the Commission does not control, cannot control, will not control, but yet we need to sort of be part of the process. We need to be a player in the process and understand what's going on as we continue to make policy that is not related to those things. So, and I think the recommendations reflect all three of those types of things. We presented the report, the draft report, to the Commission on June 11th to the Commission, and we thought you'd be interested in hearing some of the feedback from our commissioners on what they had said. And Dr. Heft was kind enough to come in and kind of help from his perspective, and Nicole Stallings was also there on behalf of MHA, provide some input and respond to any questions. So I'd be happy at some point, if they wish, they can also share their take on what the Commission said. But in general, I think the Commission expressed deep appreciation for the work of this group. Again, this is different than a lot of the other groups. It's a long report. We kept trying to find a way to pare this down to make it shorter and more concise. And it's difficult because, as you all know, there's so many aspects of the healthcare delivery world that you can't ignore. So so that's one of the things that's really different. We have a policy at the Commission. We try to keep our recommendations to 5 pages, and we just couldn't do that in this. There's so much out there. And the Commission recognized that this task was different and that it was broad. And so I just wanted to let you know that the Commission really appreciated all of your work to date. There are a couple themes that they made during the Commission meeting. One of them was, first of all, they generally agreed with both the desired goals. I think that was what we called them, or desired aspects of the system, as well as the potential options that you recommended, and I should say we together recommended. And they thought it was a good direction. It was the right path. A couple comments. One comment that several commissioners made in different ways was they emphasized urgency. There needs to be a sense of urgency, and we've heard this around this table as well. So, particularly our chairman talked about, what keeps him up at night is something we hear a lot about, and what keeps him up at night, what keeps us all up at night, is will we pass the all-payer test, the 358? We feel pretty comfortable where we are right now because Donna and the staff have made tremendous inroads in getting folks on global budget. We have a significant amount, 94% or something, of hospitals have agreed to global budget arrangements. So we feel pretty comfortable about that. The Medicare target is a moving target, and as you expressed around this room, that's a lot of your concerns, and I know some of you stay up at night thinking about that as well. But particularly the Commission, those are the things that keep them up at night. And one of the things that they said to maybe help them sleep was, if this sense of urgency, if we can make sure that this, the delivery system is reformed in the right way, and that there's alignment of the incentives, not only between the hospitals and physicians, that maybe he'd be able to sleep better, because he and others could sleep better, because we'd be on the road to be able to passing all those tests. So a sense of urgency is something that they said. And I think it's reflected in the report in several different ways. One is you all said that we need to begin operationalize. We need to begin those things that we can do today. And while we're implementing those things, we need to start creating policy for those things that may take, have a longer path, those things that we may need to go to CMMI for. So, for instance, and I think it's clear in the report, you said this several times, let's get moving on the New Jersey concept, a broadened New Jersey concept that's consistent with the all-payer model. Let's get going to find out if what Western Maryland Health System presented at the commission meeting is the right track, and if it's okay, if it's copacetic, those types of P4P arrangements are okay under our system. So those things we're going to be, and Rob's going to talk a little bit about this more later, but we're going to be driving ASAP. At the same time, Rob will also talk about is we're going to have some work groups that are going to start, smaller groups that are going to start trying to put some meat around the bones of this ISSO concept. What should be in an application, and the timing of that, and work plan for that. So we think the report reflects that sense of urgency, but the commission just wanted to reiterate that there definitely is a sense of urgency. They also acknowledge that a lot of this alignment stuff really is a major part of phase 2. Remember, the phase 2 is the total cost of care. But they also recognize that we have to pass phase 1 before we can get to phase 2. That's after year 5. And these types of arrangements will certainly help us toward passing phase 1 as well. So we can't wait for phase 2. We have to, their message was, we need to get this, whatever we can get done in the early stages to help us with phase 1. And yes, phase 2, it'll be more apparent that these alignment strategies will be more important at that phase. And as I mentioned, we did already. I think the urgency is in the report. One thing that came up, and Dr. Bone, one of our commissioners who's a physician, brings this up on occasion about LARP. That's a physician loan assistance repayment program. There was a report of MHCC several years ago, and one of the recommendations was for the commission to include an amount in rates and assessment in rates to support a LARP program that actually there's a infrastructure set up in the Maryland Higher Education Commission to do some of that. John Colmers and Secretary Sharp's team pushed very, very hard with CMMI to get this as part of the application. CMMI balked and had concerns at this stage about moving Part A money for a Part B purpose, because it's always, we've always been a Part A system, and we're not ready, and the potential for a precedent for other states and so forth. So they, despite all the effort at this stage, they said no, that would have to be something separate. And really, probably it makes even more sense in a phase 2 type arrangement for those types of things to happen. So we responded to Dr. Bone that for a couple reasons that the commission or this work group didn't focus on that. One is CMMI said this is a non-starter at this stage. 2, it's not so much about care coordination or alignment, but it's more workforce, kind of a workforce issue that we acknowledge it should be on the and John has put this, make sure this is on our radar for years. And again, as I said, it's we need to readdress this as we get closer to the phase 2, because I think maybe if we're successful, if we can prove to CMMI that the models that we put in place are successful, then we're at good standing to try to push for that on phase 2. The other thing that came up, and again after this, Dr. Heff, feel free to, if you have any other thoughts from the meeting, feel free to chime in. There was a lot of talk about the intersection between this work group and data and infrastructure. We did have a meeting with data and infrastructure, but as we'll talk about later, that has been one of the harder parts of this work group process for us, is to join, to some of these issues that really fall within or intersect with other groups, to try to get these groups together. And it's part of the reason why we're kind of reshaping I apologize for using phase 1 and phase 2 again, but phase 2 of the work group process, which starts July, that we're going to kind of regroup and try to do more where we can bring data and infrastructure people on certain issues and things like that. But they suggested that we really need to marry in a lot of ways this alignment concept and care coordination concept with the availability of data and infrastructure. CRISP, for example, CRISP is a really good resource for some of that information and data sharing. So that was really the third theme I think I heard from the commissioners as we go forward. But in bottom line is they very much liked the report, appreciated the work of the group, and they basically said, carry on, move forward with the options that you all have identified. Anybody else who was there? Donna, Rob, anybody else have any other things that I missed from the commission? Rob, Dr. Happ.
No, I think I would just echo that the commission said, get on with it. Move along, put some meat on the bones, get down the road with a strong, detailed implementation plan, and work with the various parties to get on with it. So.
Yeah, I think it really was, as Chairman Colmer said, it's a sense of urgency, and please understand it is urgent to do these things. And I think Steve Jenks mentioned and emphasized the fact that the system still, at this point, it's a house divided, and the house divided cannot stand by itself, and that there's two separate incentives on the provider side and on the hospital side, and those need to be aligned, and that's really the work to be done. So time to stop talking and start doing some work.
And I might also tell you that we meet with the folks at CMMI every week and for the implementation process, and they're extremely interested in what we're going to be doing, and ultimately would like to get a report from us maybe in August with the top leadership from CMMI, so from the Innovation Center. So, I think that once we have a plan that we're ready to present, there's high interest at CMMI in helping to move it forward. So, so I think that's also very positive.
Mm-hmm.
Any questions?
It's not a question, but it's just a comment. Dan Wynn. Inertia is very difficult to overcome. Change is very difficult. And in order to get this started, get the momentum started, I think it's very important that the incentives for the physicians are really meaningful and really get their attention. Unless that happens, you won't get the rapidity of movement that's needed.
I would agree. This is Scott from Calvert. I would agree with Dan that is critical. The other thing I think we need to do with some, and perhaps the discussions with CMI, the HSCRC staff's having would be the right place, is we need to also look and understand what are the structural reasons why there is the alignment. It's not just that physicians right now are on fee-for-service, because that can be changed relatively quickly. I mean, we have experience with capitation. But CMS itself, in a division between Part A and Part B, is driving that split. And the ways that they utilize that difference at the hospital level, but also when you're looking at trying to move things between settings, foster barriers that block efficiency. And efficiency is going to be critical in everything we do. To squeeze, we're going to need to squeeze that efficiency because we're not going to be adding money into the system, so we got to get it out of somewhere. And we have to look at where we're spending money that isn't delivering value, isn't pushing the triple aim. And unless we do that, we're only playing around the edges.
Just to add to their comments, this is Dr. Paravemba. Yeah, I think the incentives have to be great enough to promote and create an atmosphere where physicians will be actively involved. But I think we have to keep in mind that different types of physicians may have different incentives. And to drive efficiencies with certain physicians who are not, let's say, volume drivers, physicians who, are the ones who are increasing the utilization in the system, that fee-for-service may not necessarily be totally a bad thing in that arena, and that fee-for-service is not all bad for all physicians, and it could work in to incentivize and improve efficiencies, particularly for those physicians who are not the volume drivers in the system.
Hi, Orly Panich. To add to all those comments, I think in particular, when you are dealing with physicians, and I'm sure with anyone, I think that the first impression and the first start is very important. And so taking into account the differences between all the different physicians and probably making sure that it's not a one-size-fits-all, but that there is special attention given to all the different sects, I think will really work much better in terms of collaboration rather than trying to fit or fit a system that doesn't fit everyone.
This is obviously a process that has significant change associated with it, and for driving change, the principles that I think have been well established are that strong leadership, integrity are part of the number one and number two, and leadership needs to be assumed by either someone or some group in this process. Otherwise, I think it will founder, will stall. But number three is communication, and number four is over communication. And I think those are the things that I think we, once whoever establishes the leadership roles will need to clearly embrace communication and over communication as ways to get out of the blocks. Because I've said this before. I want to underscore it again that what's been happening here in this room, which is wonderful, and at the commission level is wonderful, that still the rank and file providers are relatively blind to what's been going on here, and it will be new information to the 13,500 of the 14,000 practicing physicians. So it's time to stop talking and start doing stuff.
Right. I think that's a good segue into the next item. For the rest of the day, I think we're going to talk more about process and how we get from here to there, including outreach and education and communication. Okay. So we thought we've been kind of keeping our head down, reading stuff and getting comments. thought we'd kind of step back for a minute, and I should tell you that this same presentation is being given to all the work groups about where, what the next phase, what this phase 2 means for the work groups and for everybody. And I will talk generally this first presentation about the work group process overall, the HSCRC work group process, and then Rob is going to discuss later in a separate presentation, all right, here are our recommendations, what is the next phase, what's the next step for those recommendations. Just to go back to refresh your memory, what our timeline was that in the short term, we need to get, as the advisory council said, concentrate on the caps and the targets, and the best way to do that in the short term, get hospitals on global budgets. As I mentioned earlier, we have agreements with 94% of revenue, well, 90% of hospitals, 94% of revenue. So mission accomplished. We shouldn't use that term. That didn't work for one of our presidents, did it? But I think that we've made great progress, and we've done a lot in that area. So now we're starting to shift to this this midterm, population-based. And so those are things like continuing some of the model development, some of the actually implementing or putting in place incentives for delivery changes, which some of the things you've been talking about, as well as some of the alignment strategies, some of the things you've been talking about. And then try to access and analyze data and make sure we have the infrastructure and the type of data we need to make sure that we can support care coordination and know what our guidelines are, which leads to monitoring. We're in a phase right now where we're trying to make sure that we have the most recent and most accurate data on a monthly basis so that we know where we're heading for this year. We're always a few months behind, but better than 18 months behind where we were before. And then after that, and as we talked before, we're already actually starting in many ways, to prepare for phase 2. I know the data and infrastructure work group is already trying to get access to data on total cost of care and things like that. And some of the things you've discussed tend to be, some of it could be considered a phase 2 item. But we want to make sure that we're preparing and getting what we need so that we can put together in year 3 an application for the total cost of care phase 2. So in phase 1, what have we accomplished so far in phase 1 of the public engagement process? As you know, we had the advisory council met. They provided us with a broad set of recommendations and principles. And from January through July, we've had these 4 work groups that have been meeting and focused on a set of tasks for this initial policy making of the commission. We were in a rush that, July 1st was coming quick, and there's some things that we had to get done for July 1st. Some of those things came out in recommendations. I should add, at the June 11th meeting, the commission adopted a lot of those recommendations of the work groups, things like the update factor for July 1st, and in a new way, in a more per capita based way, and trying to manage to that 358 and Medicare test. Changing the uncompensated care policy, given the fact that those who are uninsured, the profile of the uninsured population now after the ACA has been implemented is different than it was just several months ago. How we update our quality programs, there are several recommendations for readmissions and hacks, how we're going to adjust those going forward. And then, of course, as I mentioned, the global budget policy. So a lot has been done in those initial, had to get done by July 1st, and there's been this real rush. And as you know, these work groups have been meeting very, very frequently. So phase 2, beginning July, and we always anticipated this. I mean, in the plan was we have a focus on July 1, and then we can take a breath and focus on the second phase of the work group process in this phase 2, some of the longer-term implementation issues. We will be presenting in July, all the work groups will be presenting in July. Well, actually, I guess it's the staff will be presenting in July to the Commission what the future work plan is, and that some of the slides that we're presenting you today will be as part of that slideshow. And then the Advisory Council will reconvene, and I will add for those in the room that we will be adding a consumer member to that group. They will be reconvening, and we'll be bouncing off of them, getting feedback from them from all the activities of the work groups in this phase 1, January through July phase of the work group process. As you know, we've engaged a broad set of stakeholders. We've had these 4 work groups and 6 subgroups. We didn't really do much in the subgroup process, but a lot of the groups had some very technical issues that they broke out into subgroups and came up with some recommendations that way. 85 folks, including yourselves, have been involved in the process, including consumers, employers, providers, payers, hospitals. We believe, and we've been, others have told us that it's been a very, transparent process, and we've had diverse membership. And the key, I think one of the keys, and this is what the early parts of this, there was a lot of education that needed to take place. As I mentioned, I learned a lot. It was education on both sides, particularly for this group. For the other groups, the education was more one way about, what are these terms mean? And as I mentioned, I've been kind of living in this hospital bubble, and so both folks now are learning what the terms are. What are the methodologies that we've been implementing? What do they mean, and how are they done? So we did a lot of education there so that those folks could be in a position to provide some recommendations and input, feedback, and thought. We've received some white papers that have been shared publicly, and then we always provide opportunity for comment for folks who may not be on the work groups. As you know, the process has been designed to encourage broad input, and we thank you all for that. And obviously it helps very much for the Commission's decision-making process to have all of this feedback and input as they are making recommendations. Obviously in all the work groups there were areas of consensus, and there were areas where there were differences of opinion, and I think that's common throughout. You're always going to have that. And the process has been really for more input and feedback and kind of a non-voting work group, more of an advisory group type of process. So thus far, we have had some aggressive work plans to meet our deliverables for July 1st. And for staff, time and resource, it's been intense for staff to prepare a lot of the analyses and things that needed to be done, as well as for stakeholders. And to date, it's really been staff-driven because we had these tight timelines, and we had these particular deliverables that we had to meet related to policy that had to get to the Commission, in many cases in June or even May. One of the things, as I mentioned, it's been challenging is try to maximize the synergies of the various groups. I mean, like I said, I think we had a meeting with data and infrastructure. I thought it was good, but we need more in-depth communication and interaction between folks talking about both of those things. And we weren't really able to do that given the time and ability that we had to do. And I think in phase 2, it's something that we'd like to create work groups where we have folks from different types of areas of policy. And we also found that the subgroups, the smaller subgroups that deal with more technical issues, have been very successful in providing some recommendations, and then the work group, bouncing that off the work group. So what are we thinking about going forward into the next phase? Where do we see this process going? We see having less frequent meetings to allow some more time for analysis and review. We see some of these ad hoc subgroups are going to grow out of this so that we can deal with some of the smaller issues and then bring back to the work group. And the work groups are we're going to reconfigure some of these work groups. Later on, I don't know if we're prepared to really show you exactly what those work groups are going to look like yet, because we're still getting advice from our commissioners. We're going to have some executive sessions about how we're going to use staff and how we plan to put those work groups together. But I can tell you, all of you or most of you will be involved in one way, shape, or form, and kind of see this group here as almost being sort of kind of an advisory group as we get into small groups, so we can bounce things off you and get feedback from you. On certain areas, maybe not all of the areas that we've been working on so far. And the other thing is, now we're at a place, I think, too, where it doesn't have to be all staff-led. Going forward, it can be different stakeholders who actually sitting where Rob and Donna are sitting and leading some of the conversation. But staff will be, we will be part of the process. But I think we might be able to get a better dialogue and have, we're limited. Obviously, we have a small staff. We're limited with our time and our resources. So we need to know what is going on, but we want to be part of that process. And here's what Dr. Happ was talking about, is that we want more focus on outreach and education and communication. This is something that obviously was emphasized by you and was reflected in the report. At this stage, there are many items where HSCRC policies must be part really of a larger kind of state strategy. So when what we believe that the new structure, work group kind of structure is going to look like is, going to, as I mentioned, have some stakeholders leading some initiatives, but we're going to have more kind of multi-agency efforts, meaning we're going to involve more with DHMH. We'll find out more about SIM here shortly, hopefully, and we'll be able, there might be some connection there, some nexus there that we need to bring them in on. So we see, and with the data and infrastructure piece, we need MHCC and HSCRC and other state agencies to come more in the process. So not only do we see some more stakeholder-led stuff, there might be some DHMH-led stuff, and definitely more coordination that way. Related to this group, we could see the continuation of this alignment process that you've recommended, and this is an area where I could see this group potentially being sort of an advisory group, bouncing some of the things off where maybe a smaller group might come up with. So, for example, we go out and we come up with some ISSO terms, if you will. What terms might be in an application? It would be good to come back maybe to this group and get your thoughts about the direction. But I think that would be something that a smaller group could start and get your feedback on. Care coordination, that's a much broader discussion, but I could see a group designed around care coordination in care management. And as I mentioned, a lot of the other work groups have used these subgroups, and we found that has been very efficient. And care coordination, we learned very quickly, really is going to require a lot of focused attention. And HSCRC does not have to lead that discussion, because those are things that are going to happen out in the industry, but we need to be part of that discussion. We need to understand what the strategies are, what kind of care coordination strategies are out there, identify some of the needs and use cases. In other words, we need to really, our part of this could be more on a data side to support care coordination. Maybe that would be sort of a lot of the things that we could be involved with. And it may not be just HSCRC data. It may be data from DHMH, MHCC, from payers, other folks. And so other things that we see in the future work, other items are, of course, the alignment recommendations, the implementation. We need to get that moving, as our commission said, get moving down the road on that. Outreach and education is a priority. Started a little bit of discussion about long-term care and post-acute care strategies. That was sort of on the agenda. I think that might be it could be part of the larger care coordination discussion, and so could potentially evidence-based care. And some of that might actually fall into some of the performance measurement side as well. And then the tort reform and defensive medicine issue, that you may recall, there was a provision in House Bill 298 that asked one of the work groups to consider the impact and implications that defensive medicine has on hospital cost and the goals of the all-payer model. So that's something that will be discussed potentially with a smaller group and maybe have a study done or something like that so that we can have some thoughts and a report out on that as well. What are the next steps? For this group anyway, staff and stakeholder is going to develop a work plan for the alignment recommendations, and actually Rob is going to talk about in a minute what some of the work plan is. Some may be developed in a small group and bring back to you as feedback. Care coordination is going to be another thing that we're going to be moving on. It might be a different group. Again, we'd like to have some data folks in that group and more kind of involving other state agencies. Have some more subgroups, particularly around physician alignment and long-term care and some other things, maybe defensive medicine. We see in terms of a group like this, of this size, that maybe we will have a next meeting probably in the fall to bounce off of you what some of the other groups have been doing and review the progress that they have made on the areas that we have made on the areas that you recommended. And so we see less frequent meetings to allow more time for some of this work. I think we envision probably quarterly meetings with this group. But that doesn't mean that many of you will be involved in some of these smaller groups that will be more frequently and deal with particular issues. So that's where the entire kind of work group process all along, that's the direction that we see things going. We will confirm with our commission after our next executive session that this is the process that we're going to use. But this is sort of what we anticipated from the beginning. This is not really a change from what we anticipated at the beginning. So Rob is going to talk more about your recommendations and the plan to try to implement those. But are there any questions about kind of the general concept for the work group process?
One of the slides said RC policy must be considered as part of larger state strategy. So are we going to have some meetings about the larger state strategy?
And that's part of the reason why we need to engage, DHMH and others. And I think part of the larger, SIM is just one thing, but it would be interesting to know what's the status of SIM, because that can change direction. So we would definitely need to see where we are with that, and there would be a strategy around that. There are many other. So one of the state strategies is data infrastructure, the use of CRISP and other methods to access data and to do analytics. So that's more of an HSCRC thing. That would be something that obviously we'll need to work with the department on. Other things.
Well, like for example, if we're trying to bring data together, we have the all-payer claims database with MHCC, and we're focused on getting Medicare data. So some of those aspects are related to data infrastructure issues, where we actually have multiple agencies that are part of the process, including Medicaid and MHCC and HSCRC. And we're trying to say, well, let's do that as a multi-agency effort with our stakeholders, so that they're not having to have meetings, different meetings on the same topic with all three of our agencies. Let's try to do this in an efficient and collaborative way across agency as we move some of those topics down the road. That doesn't apply to every topic that we'll be looking at, but data is one where there's definitely multi-agency interest, and care coordination has multi-agency interest with SIM and just with other Medicaid strategies. For example, what's Medicaid going to do with the duals, or what's, et cetera, and so forth. So there's a lot of multi-stakeholder things when we get into the topic of care coordination. So those are examples of where we really want to make sure that we have the parties at the table that can inform the discussion best, and with your valuable time as we move down the road. Does that make sense, Dr. Nguyen?
I think so. So if we sort of step back, some of those are strategies, some of those are tactics. Is there a state vision? I mean, is it articulated somewhere that it's available? Is there a vision? And if you have a vision, then you have the strategies. So, I mean, I'm not asking for an answer today. I mean, at some point it would be good to know sort of the biggest picture.
Well, in the care coordination, I mean, for example, if you're talking about care coordination, I don't, I think that's part of bringing the parties together, is to make sure that we do arrive at a common vision.
I guess I'm thinking of this as larger.
But even
I'm thinking, what's the larger state vision? And I'm not asking for an answer now. I mean, at some point it'd be good for the group to really see, what's the largest, what's the state vision?
Well, I think the larger state vision is the triple aim, is the three-part aim. I don't know if that's too large for you. Yeah, but I think it's the basis for everything that the state is doing, including the all-payer model, including SIM, including SHIP, the SHIP program. All of these things together really kind of wrap up. That is really the basis. Now, if you want to get a little, 10,000 feet down from that, you're right. We would have to kind of compartmentalize and think more about how to respond to that. But it's there. It's just I couldn't probably tell you exactly how, at what level, what that is right now.
Yeah, it seems to me it's sort of the all-payer model with a globally budgeted rate structure is it's a very unique system in the country, and I think it's, and as you say, that if you have this all-payer model that's globally budgeted, then now your strategies. What are the strategies to make those global budgets, the strategies and tools you use to be successful under that model? But I think, to me, that's the model.
But I think the state and DHMH has been executing a number of strategies, and so and that are part of a vision. And I think you're saying, well, we don't know exactly what those are, and if you're going to have a communication plan with the field, it sure would be nice if you pull some of those other things in. So if we're doing state health improvement plans and community health improvement plans and health enterprise zones, and can we just create a little bit of a broader picture for folks about what we're trying to do in these different pieces of the strategy and how it fits together with what we're doing at the HSCRC. And so I think what I hear you saying is, you know, state you need to do a better job of communicating that, and this is a good idea to bring these stakeholders together in these groups, but also make sure that as you do that, you bring these strategies and visions to people in a more cohesive way instead of here's the HSCRC piece. And is that what I hear you saying, Dr. Wynn? I think that's a good that's good advice. So appreciate that.
All right, so Rob, you ready to move to the next part of the presentation?
Yeah, sure. So Steve, thank you. So hopefully that puts into context the work we've done. Actually, okay. Oh, okay, you already had me there.
Yeah,
thank
I had you there.
Okay, good. So hopefully that puts into context not only some of the work that we've done, but the work that the other work groups have done, and how this will all come together, how our work and other work will happen as we move into, sort of, we'll refer to as phase 2 of the planning and implementation and policy development process. As Steve said, we got the full report sent out. I think that just went out yesterday. You already had the executive summary. It's consistent with that. The executive summary obviously had the high-level recommendations, but I really appreciate the group's work on the full report and the executive summary. Many of you took the time to read and go through the report, so hopefully in that which was sent out yesterday, we did go back and really try to incorporate lots of comments along the way that were very helpful, so thank you. And of course, the report is just the beginning, as Steve said. The commissioners, as he reported, reacted favorably, with some of the key messages being, Donna said, get on with it, and have a sense of urgency, and that a house divided doesn't work, and so we need to fix those incentives. That's what this sense of urgency and get on with it is about. So that's what that's what we'll be doing, and obviously we'll go through some of the options. Although we've been through these before, they haven't changed much from our last meeting. Start by saying, in general, they're in the sort of the alignment recommendations and then care coordination recommendations. I know we'll get to that on future pages, but just here I'd mention that in my own mind, we really started with the alignment pieces because those are, it's a little more discrete in terms of vision, coming up with the ideas to move forward with. We have to, they're policy changes. They're things that there might be some barriers we have to clear in the 2015 legislative session, whereas the care coordination piece will be more ongoing. And so, as you of course know, I feel as though we did a good job as a group coming up with discrete recommendations around the alignment strategies, and that's the work we'll now get on with, and then the care coordination piece will continue to be ongoing. I also think that we've talked a lot about the HSCRC's role, the difference between being a regulator, a catalyst, and an advocate, and with the alignment models, a little bit more of a regulator in a sense in terms of helping foster them and having to work with CMS and others to push them through. The care coordination piece, again, will be more ongoing and sort of more of an advocate role. Scott, did you?
Yeah, Rob, I just had one observation on this slide. I think there's an entity that's missing both in the second sub-bullet and the second full bullet, which is the payers. One of the big challenges on the non-hospital or deregulated side, even for hospital, is the lack of all-payerness, the fact that different physicians, and Dr. Hack could probably talk about it in far more detail than I am, because he has practices that are both in the state MMPP, PCMH, and those that are only in the Care First one. And then, in both programs, there are payers and patients that are excluded. And we need to have everybody at the table, and that includes payers.
It's funny. as I looked down at my piece of paper where I was sort of jotting notes as things to say, I wrote, build appropriate incentives, hosp/physician, hosp/payer. So I put it in my notes off to the side, but you're right, it's not in the book. So I would absolutely agree with that comment. So thank you for the observation. You're right. I think we talk a lot about things that we can do, things where there are barriers, and we need to clear barriers, and things that we can do today. I think there's a lot of places where hospitals and physicians and payers, we've talked a lot about Medicare because there are barriers, whereas with a lot of the private payers, commercial payers, those barriers don't exist. You can just do it. And now for the first time, you have the same incentive with those payers in many cases, and so it's a real opportunity to get to work. So thank you. Okay, so just moving on with the recommendations. When I look at the first bullet and all those sub-bullets, has a lot to do with facilitation and being a catalyst, as it says, a lot to do with communication and over-communication in terms of promoting awareness of the model. And there's, we've talked a lot about developing of infrastructure places where the HSCRC could play a role. I think Sana mentioned a little while ago that facilitating on the data side within care coordination could be a place where the HSCRC could play a role. That comes through there. On the second bullet, again, playing a catalyst to encourage hospitals, physicians, and payers, as Scott, you very well point out, to work collaboratively towards models that make sense. We've talked about, Barry has been a big advocate, and many of us have talked about physician contracts, the structure of existing physician contracts having a lot of fee-for-service, and that there's might be opportunities to encourage triple aim incentives. Of course, Dr. Parabemba, you pointed out before that there's different incentives, and Orly and others have made the point that there's different physicians are in different positions and control different things, and so there's different opportunities to work with different physicians. And I think our recommendations, create a broad spectrum of opportunities, because we, from the gain sharing side to the shared savings side to the ISSO side. On the next page, the first bullet, we've referred to it as pay for performance, and the Western Maryland model that's in the full report is an attachment. As we've said, we'll work to confirm the ability to work on programs like that without the need for additional regulatory approval. The next bullet, of course, has to do with the New Jersey-related gain-sharing model, for which AMS came in and made a presentation. We've discussed that a lot. We think that's an opportunity, and that can work collaboratively with the other models. Of course, the model in New Jersey, historically, they've had more of a cost per case incentive being on the DRG system. We, of course, have more broad incentives, so we'd like to work to expand that model over time to be consistent with the goals of our model, to incorporate more volume-related incentives, although I think that one does have some related to readmissions, as the nation has incorporated readmissions. Of course, the next bullet is this ISSO option we've talked about. I think that's has been our grandest vision in many ways, and I think it's just tremendously appropriate and relevant given the structure of our system. I think it holds great promise. I think ACOs offer opportunity, but this could be a much more broad, more efficient structure to get at the whole Medicare fee-for-service population. In Maryland, I think, as Donna said, this is, the concept's been broached with CMMI in the ongoing meetings. There's interest, and so that's a place where we'll spend a lot of time. The HSCRC will play a role developing a work plan, working with the industry to present to CMMI. Barry?
There we go. It may, on one hand, appear frivolous, but I think it's a serious comment. I think you should drop the I from ISSO. I think it should be SSO, just Shared Savings Organization. I think it doesn't roll off the tongue. It sounds too much like ISIS. And every time you say it, that's my reaction. And we're going to hear about ISIS a whole lot. And it's, you know, it's no big deal if you take this comment or not. But I suggest just SSO. A lot of things are just MCO, HMO. I mean, I just, yeah. I think I like 3 initials, and I don't like the I. And I'm not saying it shouldn't be integrated, but for whatever it's worth, every time I hear it, I think of ISIS. Thank you.
There you go. 3.
No.
It's
your communication issue. It's what those 30,000 doctors and officials. Yeah.
Right.
And then you add, if you're going to start playing with the name, do we want it to be focused on shared savings from a messaging or on coordinated care? You know, do we want to be telling the doctors we're here about savings, or we want to tell them that we're here about taking care of patients better? Which is more likely to get resonance? It's all semantics, but I agree with you. It is important, as whichever group deals with that, consider the name.
Yeah.
Can I interject the comments? It may be completely a non sequitur here, but it just reminded me that the beauty of the New Jersey model, at least from where I was sitting, was that there was a governance structure there that incorporated a lot of physicians, and the physicians had an active part in that. And I'd like to see some of that either in the guidelines or going forward, that the governance has, that there's a particular attention to having providers involved. I think you know, what we really need to do now is put the meat on the bones here, if you will, and really develop some of the concepts. And it may be possible that you know, if we're going to do the AMS model, if we start thinking about the concept of integrated shared savings models, whatever, ISS, or whatever we decide on, but you know, maybe we even ought to integrate the governance of that model with some pay for performance and this all together from the get-go, so that we're not and having a lot of physicians involved in the process, so that we're not actually creating multiple infrastructures from the get-go on the things that we're trying to do here. So I actually think that we really need to drive that process earlier in the thinking of really getting a lot of physician participation in all of the above, and probably in one organization or one approach, so that we're not going down different. I mean, even these things need to be integrated, because they could potentially be duplicative or, you know, overlapping, and so I think we have to have them all working together.
Right, and they can also be complementary.
And so I fully agree with what you're saying. And so you know, it's our collective job, including MedChi and other physician leadership, to help drive that process now down the road.
Thanks, Willie. Let's see. The next bullet in my mind has 2 distinct parts, in a sense. One is, could have made it 2 bullets. One is the encouraging, expanding alignment models across payers, sort of the idea of not giving physicians different incentives with different payers, to the extent that we can encourage models and metrics that are similar across payers. That would be helpful. To the extent that payers in the industry just do that on their own, again, we'll have a lot to do with just what goes on out in the industry as payers. If we develop something for an ISSO, an SSO, a CCO, whatever we call it, as the metrics get developed for that, if they're the right metrics, if they encourage triple aim, it may then be, often you see that the commercial market follows Medicare as the biggest payer. It might be that commercial payers start to use those same metrics to make it more consistent for the physician.
And that we also look, as we go down that road, at metrics that are already being used. Absolutely. So that we're trying to be mindful of those that are already being widely used and seeing if they're the right ones to take us down the road, so that we're not having a whole new set of metrics, if possible.
Right. So especially if they're generating results, it gives us quite a leg to stand on, as we're saying to CMS. We would like to use these waivers to develop this program to encourage care coordination and care management, and look at the good things that are happening in the private industry. Look at what commercial payers have created by putting the right incentives into place. So that's why we're asking you to enable us to do this for Medicare. So you're right, Don. It definitely sort of goes in both directions. And the next part of this bullet has to do with determining if there's legislative or regulatory changes necessary to achieve the options. This is both at the federal level as well as the state level, and we'll work with the industry. We've certainly heard a lot. You'll notice in the final report, thanks to Peter Parvis for putting together a good summary of what is out there, as well as Stan Lessman and others at the Commission have worked on that. We've gotten a lot of good input on issues we may have to address. And then the next bullet is encouragement of the types of models that already exist, and just this general idea of staging, and that since we do have a sense of urgency, and we do need to meet the models test in the short term, to do what's possible today and take advantage of existing models that are available while pushing forward on broader-based population models, and that they can be collaborative and complementary as we move forward. This I talked, Barry.
I just wanted to go back to the name just for a second.
Sure.
In light of Scott's comment, I just wanted to offer another version of this,
sure,
which is APO, which is an all-payer organization, and it really is the difference. I agree that you're trying to do this statewide, but I'm still trying to react to this notion of all those physicians who have no idea what we're doing and might actually find something attractive. And I don't think ISO communicates much, and maybe communicating the all-payer aspect of it would be appealing to physicians who are really quite, get quite annoyed by all of their dealings with multiple payers.
No.
Anyway, whatever that's worth. Thanks.
No, I think that's fine. I've certainly been through processes where we've spent, months and months and months and reviewed, nice big boards, with names of organizations. So if we can come up with it in, a small portion of a meeting, that'll have been very efficient in my experience. So talked about this a little before, the two broad categories on which we've been focused. I don't think we need to go through, we've talked through the alignment models, talked a little bit about, a lot of this was buried within the other bullets, but those are the two areas we've been focused on. And then the next two slides talk about the work plan and where this is going to go. This sort of fits into the context that Steve talked about before, sort of this, we're not necessarily going to be leading all these pieces, that we're going to be a broader discussion, some piece led by industry, many pieces with us collaborating with the HMH and the MHCC, and it'll be a broad effort, but there's some places where we will be taking the lead, and of course in many places we'll be at the table. On the care coordination side, it shows that we do anticipate getting back together. As Steve said, we're likely to meet quarterly. It highlights that we hope to know more about SIM in the coming months. We hope to, we're facilitating getting data, as Donna has talked about. And so we have a vision for what will happen through the fall and into the first quarter of 2015. So that's the care coordination side. And then the alignment, again, the alignment side is a little more discrete, a little more specific. We will, in the summer, we'll work to start to put the meat on the bones, if you will, of the things where the recommendations, putting some pen to paper, I guess fingers to keyboard, however you say it, and start to put together the specific recommendations to get input from the industry, to get input from subgroups, so that we can go to CMS or CMMI or anyone else as necessary to get things approved and to move forward with these recommendations. Of course, again, some of them are a little more discreet, getting approval. Some of them are, provider outreach and education, very ongoing. And I think that's really it. So we'd be happy to take any questions. Terry?
Everybody else may understand this, but during the presentation, the three of you all referred to SIM, S-I-M, and it's also in this slide. You want to explain SIM to everybody? Could one of you do that?
Sure. And I know. Sure. And I know. I think is Laura on the phone? Okay. All right. So I only mentioned Laura because she's the. I think Donna, you can talk about it, but I think she's the point person at DHMH with SIM.
Yeah. Sure. SIM is a state. SIM stands for State Innovation Model, and the over the last year, the Department of Health and Mental Hygiene has been working on some development of concepts and around how could we bring together community-based organizations, primary care, and care coordination on a statewide basis with a particular focus on high-needs patients. So, if we start looking for the 35,000 or 40,000 people in the state that are really high-need patients, how can we work across and create a model that will serve the needs of those patients in particular, and so that's really what the focus has been on. And the federal government it started with a federal government grant to the state, and now there's a competitive bidding process, if you will, for phase 2, which is to say, okay, well, you did some preliminary field work there. Now apply for the next step to take it down the road, and so that's a competitive process. And there's been, I would say, there's been a lot of discussion of the model with different groups in the state, and I wouldn't say that there's consensus across all groups about how the process should be moved down the road. So I think the application, also the federal government originally was going to fund it 9 months ago, and the funding timeline has slid considerably on the federal side, and they've restructured it, et cetera, and so forth. So I think it's still in a stage of morphing a little bit. I know that may not have clarified it a lot, but at least it put a name to the acronym.
Yeah, it was just the acronym that CMMI attached, State Innovation Model, when they put it out for Phase 1. I forget how many they referred to it as Phase 1 as a planning grant. I would say in the neighborhood of 9. I forget how many states got a planning grant. Somewhere in the neighborhood of 9, maybe. I think it was a couple $1 million. And DHMH did. I've looked at. They developed sort of hot-spotting tools. They use data. You're able to drill down by county, by zip code, to look at where high-risk patients are. And so the idea was to use this. Now you have sort of the hot-spotting data, and the implementation grant would give money to then go do something about it. And so the planning grant preceded the approval of the all-payer model, but you can sort of have a sense that now with the all-payer model in place and this vision for hot-spotting and focusing on high-risk patients, if you could get the Phase 2 planning grant, it would bring in some federal money and vision as a tool, if you will, just one more thing to help make the model work.
And to help pay for the infrastructure that would work for everybody. It would work for the physicians. It would work for other providers, for hospitals, for the payers. So it could be an opportunity to gain funding for some infrastructure that could be very helpful.
Other questions? Comments? I think that's it. So I know it's been a fair amount of work over these last few months with early morning. So thank you again, as we've said.
Just have an opportunity. Anybody from the audience or public, not part of the group, would like to make a statement, comment? Come on up to the table and get on the mic, Barbara. Thanks.
Thank you, Barbara Brookside. Let me sit at the table last meeting in Dr. Paravemba's stead, but just kind of comment, because it is so starkly clear that the comparison in terms of what the HSCRC is doing on the hospital side, which is predicated on the 40 years experience of the waiver and the data and resources that you have and the expertise that the HSCRC has, and even going to the fact that in moving to the new waiver, you had the TPR hospitals as a springboard of experience to base the expansion and for the rest of the hospitals to use that background knowledge. And that I think everybody understands and appreciates the urgency for the reforms in Maryland to work well, but I think it's an entirely different starting point with the physicians. And I think one thing I think that it would be good to hear more about, and this takes not just hearing, but there's a lot of language. I'm trying to remember that's in the report about being a catalyst and so on. But I think there needs to be some devotion of resources to looking at what is working well in the physician environment in Maryland, and being sure that what is taking place here is not going to disrupt what works well. So in the vein of meeting newly defined goals in this new environment, I think that needs a devotion of some resources, not just be a catalyst to move in new ways, but to say, okay, in the surgical episode, this is what's working well. In terms of emergency care, this is what's working well. And
So I just wanted to say that. I think that's really important. And I know it's come up here, and I've heard you all say this, but it's also figuring out where the resources are going to come from for the physicians to do that. That's not hospital money. So those are just a couple of comments sitting in and thinking about that I wanted to share.
Thank you, Barbara.
Thank you.
Any other comments from anyone on the committee or not on the committee or anyone on the phone? No? Well, I think with that, again,
yeah, just a couple comments. Yeah, I think that given the sense of urgency, if there are strategies out there, and I think particularly the care coordination group, one of the things that they would do is look at what is going on there that's in care coordination that's working now. And to the extent that there are things that are working now, there's some demonstration projects that are currently out there. We want to learn about those, see what's working, and maybe even maybe or maybe not endorse some of those. But it doesn't, you're right, it doesn't make sense for us if there are things out there that are working now for us to create something entirely new. And the thing is, and I think somebody said this earlier, maybe it was Orly, but in Maryland, the reasons for lack of care coordination are diverse across the state. And it's dependent on the community in which the physician or the hospital is serving. So there's really I'm going to predict that there's no one size fits all particularly for care coordination. But there may be some strategies that can be successful fairly broadly. There may be others that for particular populations work better. So I would agree with you if there's some things out there that we need to learn, that part of the care coordination group we're going to learn about, that resources have already been put into it, and we find that and when I say successful, maybe you have a different definition of successful, but in my mind, successful means that it achieves the three-part aim and the goals of the all-payer model. Okay, and so that's I think the prism or whatever
And I heard you say something else. So I maybe heard you say two things. So one of the things I heard you say is make sure you know what you've already got. So if we don't have patients having to have long waits, and we have most doctors accepting payments from the insurers as payment, and know what you've got in hand before you start fiddling with it, is what I heard you say in one hand. And so I think that's one thing you said, and then certainly making sure that you devote resources that are expert at and can look at what's worked elsewhere in an appropriate context of what might work here in Maryland. So those were the kind of two things that I heard you saying. Is that a correct interpretation?
I think that is, and I would say even to the point, and also important, and these guys know it better, is standard of care. Let's say, and I was my office was in a meeting about peer review contracts earlier this week, and there was discussion about, standard of care, and there was somebody from a national peer review group who recognized two of the contract groups in Maryland, one in emergency medicine, one in anesthesia, as having such wonderful peer review processes. And, I'm saying, and this is it, sometimes even in the coordinated care environment, without having a pilot right now, and particularly, and this is more of my experience and certainly theirs, in a hospital setting, we've got really smooth running, good relationships going in the surgical episode. So maybe we just look at how that is. it's the climate, it's the environment, it's the physicians working well together and with whoever else is involved. So, but I think you did capture it. But I think I hear you about, well, maybe it was Steve, maybe my goals are different than, are the goals triple aim? The goals are good patient care, and and it's the good standard of care and access, which in the appropriate setting that I think everyone is working toward.
I think that's the point I was making.
Yeah.
And I don't think that they're mutually exclusive. I think to Dr. Wynn's point, there's some things that are strategies, like having coordinated care or assuring that the workforce meets the needs of the population served. But beneath those are a whole host of tactics, some which will be excellent, some which will not be so excellent. And I think the organization will describe what the strategies are, and then each tactic will either support or not support those strategies. Some will be good, some will be scalable. Some will be good and some will not be scalable. They'll just be very local because that's the way healthcare is delivered. And I think we'll discover that along the way. But I think it is, and again to Dr. Wynn's point, it's important to recognize what the strategies are and differentiate those from the individual tactics to achieve those strategies.
Thank you.
In the end, I think no matter how hard we look, I think there are some efficiencies that already exist in the system, and we should obviously just carry them forward. But I think there's always we're going to require some resource allocation in care coordination and development of programs, particularly targeting the specialties. There's a lot of programs that the primary care side fits into, and I think that's the right place to start. But I think specialty care, disease-specific care, population-based care is going to require a lot of resources, and there's some question as to where those resources would come to create the care coordination and infrastructure. The SIM might be that grant may be something that could be utilized to that end, but right now there's a little bit of how can we put all this together? How can we get the infrastructure to collect data, to get the care coordinators that would be necessary to transform the care for the patients along the triple aim and so forth.
Okay. Any other comments? No? Well, I think, again, thank you all. I know it's been a number of meetings over these last few months, a little less often going forward, but I'm sure we'll be in touch.
Thank you.
So thank you.
Well, we really like